Bismillah ar-Rahman ar-Rahim. Dear guests, students, can you be seated please, so that we can start the session. We are having little bit change in our today's program, because our international guests having their flights. So we are starting our ureteric stone session before, and then we'll carry on with the free papers. So Chandra Sakra, please come on the stage. Professor Majid Rana, sir, please. Dr. Waqar Memon, Dr. Sayyid Qadri from Taba, please join the stage. So in this we are missing Atif, who's on the way to joining us. So we are going to start with Dr. Mahesh Adhikari. Sir, please come and have your lecture.
Start. Paper is expulsion therapy. Paper. So what will do? You will write. Please, sir. Shall we start? Please, sir. Okay. Good morning, everyone. Respected chairpersons, faculties, and all the delegates. I again like to thank the organizing committee for inviting me and then be a part of this very auspicious meeting. So I'm going to spend another 20 minutes, around 20 minutes, in the recent advance. Most of the things has been covered yesterday, bit by bit in different lectures. So I'll just go through. Going through all these slides slowly. Surgery in all surgical specialties in recent decades, and the RIRS represents an area in which there have been numerous advances that have resulted in excellent patient outcome and low morbidity. So endourology is basically equivalent to engine urology. So it's a marriage between engineering and urology. So the advancement in engineering has actually took urology to a different level. So the development of small caliber flexible devices with maximum deflections and other development of other accessories actually have permitted a better stone clearance in the upper tract. So I've shown this slide yesterday also. The ureteroscopic, flexible ureteroscopic rate has increased tremendously while PCNL is in constant phase and the shock lithotripsy is really going down. So why flexible ureteroscopy surgery is in rising trends? Basically, the shorter hospital stay, reasonable cost, earlier return to work. Most of our patients in our hospital, they are not admitted in RIRS. So improved cosmesis, definitely there is no incisions, nothing. And because of the other procedures which has suboptimal results, and RIRS is actually increasing. So the first, actually the flexible URS, designed by Marshall in 1964, actually the ureteroscope, he used 26 frames cystoscope to visualize the ureter. Later 9 frames flexible ureteroscope was used for only diagnostic purpose. And then, so basically Grasso et al. Reported an advanced flexible URS with a 7.5 French deep and then 120 degree down, 170 degree deflection systems. And then with the introduction of laser, so Bagley and Erhard actually reported the first use of Holman laser for ureteral stones. Then the actual flexible URS scope treatment started, and Grasso et al. In 1998 actually published a first series of flexible URS. 2001, then the two-way deflection system, 270 degree up to 70 down, was actually introduced with a strong durability, and 2006 the first digital scope was introduced. So these are the two landmark papers on RIRS, 1998 by Grasso et al. And the Sofer et al. In 1999. These are the main actually initial landmark papers in RIRS, which actually showed a very good stone-free rate in both the papers. So in the guidelines, we normally follow the European guidelines. They mention that the less than 20 mm stones is ideal for using the flexible URS, but some of the people are doing even larger stones, and some of the people I've seen doing for even a stag-on calculus, 2 hours, 3 hours, and different, stage procedures. So what are the recent advancements in flexible ureteroscopy? So there's a high-power laser machines, vision, and there's robotic systems coming up. The simulation is there. Thulium fiber laser have changed the era of laser lithotripsy, irrigation systems, and then signal transmission, and there are so many things. So basically there are two types of flexible URS. One is fiber optic, and another is digital one. So digital also there are two types actually, CCD and the CMOS. Basically CCD and CSOM both are processor that actually carry digital signal to the image processor, which is converted to image in the real time. CSOM actually, this one CMOS, complementary metal oxide semiconductor, it requires less energy and process image very fast and run at a very cool temperature, and it's less expensive than CCD. So this is incorporated in the recent flexible URS. So basically there are reusable endoscopes and single-use flexible ureteroscope. There is a paper that comparing the cost of the single-use and the reusable flexible URS. So the single-use is actually expensive than the reusable ones, but so there are different types of scopes are available by different companies. Most of them has 270 degrees up and down deflections. Most of them have 80 degree to 110 degrees field of vision. These are all optical systems. and the working channel are 3.6. And diameters were 8 to 8, or there's smaller ones also, I'll come later. So these are fiber optic, and they changed into digital ones. The digital one, they are produced by all the named companies like Wolf, Olympus, Acme stores and all. So why there is a single-use flexible ureteroscope was introduced? So there are many reasons. Like there's the reusable ones are expensive, and there's a chance of breakage while doing so many cases like this, like large hard kidney stones, lower pole stones. When you angle a lot, there's a chance of breakage. Anterior lower pole stones, drug resistance bacteria and urine ulcers. So if you have a recurrent infections, better use a single use. And then anomalous renal anatomy, where negotiation may be difficult and there's a chance of breakage of the instrument, and used by novice trainee. So for beginners, it's better to have a single-use device. But this is easily said than done. Single-use devices are expensive, especially for countries like ours, where finance is a major issue. So this one is a paper published by our team in Nepal. We use the single-use device multiple times. So when you can use a reusable one again and again, why can't you use a single-use device as long as it works? So I used this machine, this disposable. I'm exclusively using this single-use device, and using in an average 5 case. 5 case can be done with one device. So the cost has come down. The cost around for one case around in terms of Pakistani currency around 50,000 for the scope only. So but if you compare with the cost maintenance of the reusable ones, they're quite expensive, and the average case done by a reusable one is around 30 to 50 cases in a literature. So if you break the reusable ones for countries like ours, it's very difficult to get it. I mean, the other one is very difficult. So I have bought a bunch of flexible, disposable ones, and then I can use. I mean, if one is broken, then you can easily get another. It's quite cheaper than the reusable ones. So there are different types of single-use flexible URS. The first one produced by the Boston Scientific, Lutheview, so which we are using nowadays. And there are Pusan companies, Chinese companies are there, and they have nowadays they're coming with a very small, even a smaller flexible URS, disposable ones, and they're quite cheap. They are quite cheaper, and they last as long as it works. So I've been using this one, flexible cystoscope by Ambu company. They are actually supposed to be a disposable. Flexible cystoscope is a Ambu company, supposed to be a disposable, but I have been using one cystoscope for almost 100 cases. So it's economically very viable. It's supposed to be disposable, but we can't dispose. Every case we can't afford 50,000 per one case. So I've been using one cystoscope for almost 100 cases, and there has not been any case report of infection as well. So it's quite, for a country like ours, we are reusing the disposable ones and making maximum use of it. The slimmest single-use FRS is actually produced by Pusan company, 7.5 French tip, and I've also used this one. It's very, very handy instrument, and then it lasts. Initially it was not time bound. Now they have kept it. I mean, they had make it a time bound 4 hours only. Initially you could have used it as long as it works. This slimmest FURS, you can actually use 1200 micron laser fiber also. The another slimmest reusable FRS is by Olympus. This has a 4.9 French tip, but this needs 50 micron laser fiber, which comes only with TFL and that TFL fiber is disposable, cannot reuse. So it is not viable in our setup. So we have many basket and stone extractors sometimes needed during flexible URS, especially for lower pole stones. And these are tipless baskets usually used to relocate stones from the lower pole to the favorable site. But we have not been using any. Personally, I never use baskets because I use this one, disposable flexible URS, which I can easily use in the lower pole or any site. That gives the advantage of the disposable ones. So there has been improvement in the laser fiber also. Definitely bulk tip is better than the straight tip, but it's expensive. The bulk tip has comparable comminution, tip degradations, and ureteroscope deflection is not a problem with a good stone free rate while exhibiting reduced insertion force. So there's little damage to the ureter or the PCS even when aggressively deflected. Ureter-axis sheath was produced, described by Takayasu in 1974, supposed to actually increase the inflow and outflow of the fluid that we use to irrigate, and supposed to reduce the urosepsis and subrenal hematoma, but there are different companies available ureter-axis sheath, but it has recent meta-analysis, 8 trials and over 3,000 patients concluded that use of UAS does not lead to any significant difference in stone free rate, but was associated with high complication rates. So in my practice, I use axis sheath in only 20% of the cases. 80% of the cases I actually directly negotiate the scope over the guide wire. So this has been the use of ureter-axis sheath is now being challenged by the literature. So another thing is irrigation method. So normally handheld activated syringe-based system was historically used, but there are systems available like pathfinders, and recently they have developed a Peditrol, which can actually control the flow of irrigation as per your need. So there is another system, single action pumping system. It's quite cheaper system that you just it's just like a simple syringe, but the one-way valve actually provide automatic refill of the syringe for convenient and immediate irrigation, and it has shown that significantly greater intrarenal pressure than the pathfinder and the back squeeze. But you should be very vigilant because you may be increasing the intrarenal pressure unnecessarily. So there are other pressurized irrigation bags that we normally use to irrigate the renal systems, and there are automatic irrigation pumps also available. But again, the same thing, you are scared of increasing the intrarenal pressure and causing infections. So another system is they have introduced a pressure wire, actually a different pressure wire that can actually control intrarenal pressure, and then you can actually continuously monitor the intrarenal pressure and then irrigate accordingly. So now they're coming up with a patented intelligent system where the irrigation system itself detects the pressure in the pelvic calcium system, and then they accordingly adjust the flow of the irrigations. But despite the availability of many novel systems, routine use of passive gravitational pressure is the safest approach, because we are not inadvertently increasing the pressure inside the renal pelvic calcium systems. Holbein lasers have been discussed yesterday in detail by Professor Hamad. I just want to go through the Holbein lasers. Basically, There are two ways. The mechanism of stone break is two ways. One photochemical and another is photothermal effect of the that breaks the stones. So basically, there are parameters like pulse energy, total energy emitted in a single pulse, frequency, and the power. Power is frequency plus energy. And increasing pulse energy is directly proportional to the stone ablation volume. And increasing pulse energy results in improved fragmentations. So high pulse energy in a low power system, actually there's a degradation of the fiber tip, which is called the burn back effect, and there's also high retropulsion of the stones. So the high power Holmium-Yack laser was introduced, which can actually deliver high energy and a high frequency. And later, the Luminous company, the Israeli company, they actually developed the Moses effect. The Moses effect actually reduces energy loss and improve fragmentations, reducing stone retropulsion by up to 50 times. There are similar systems. Moses effect also, I mean, there are similar, this is by the Moses effect by the Luminous company only. But the similar pulse modulating principles were invented by the Quanta systems, that is called virtual basket or vapor tunnel technology. So this has been discussed yesterday, so I'm not going to in detail that low power Holmium laser and the high power Holmium laser. And then, so basically the difference is Holmium-Yack laser, the low power and high power. The high power is a collection of many cavities and it delivers a high energy, but you need a very good cooling system. Thulium fiber laser, in contrast, is actually excited by the diode, and then there are silica implicated in the thulium fiber laser, and that delivers energy. So basically, thulium fiber has a fourfold stone ablation threshold compared to Holmium-Yack. It can fragment all the stones, and frequency can actually exceeds 1000, which is not possible from Holmium-Yack. And then stone ablation on high power energy setting with Holmium-Yack laser is similar to low power in thulium laser. So thulium fiber laser has shown promising results than the Holmium-Yack lasers. There's some difference. So Holmium-Yack laser is basically pulse laser. That means breaking the stones with a hammer, whereas a continuous laser is thulium fiber laser is a continuous laser. That means it is like a continuous drill that is used to break the concretes. Basically, the fiber size lowest limit in Holmium-Yack is 200, whereas in TFL is 50 microns. Stone free rate is seen to be higher in TFL, and the operating time also is less in TFL, and intraoperative adverse effects also seen to be lower in TFL. So TFL seems to be favorable than the Holmium-Yack laser, but a lot of studies needed to prove the efficacy of TFL. So why there's a robotic system assisting the FA virus introduced? Why? Because you must be knowing that when we are doing this flexible URS, there's a lot of back problems. There are a lot of compression problems. A lot of our surgeons has actually suffered from the disc problems after doing a flexible URS, because there's the ergonomics is quite different while breaking the stones with the laser. Your whole weight falls on one side of the body, and then there's a lot of problem. I myself stopped doing it for 1 year, and my junior colleague started doing it, and he also had some problem. So this is ergonomics is a little bit problem with the flexible URS. So this kind of system have come up to actually address the problems. So hand problems are also seen in the urologist. So the robotic system has 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 actually improved surgeons' dexterity and ergonomics restrictions. It's the first system was installed in Germany. They have done 40 renal units, 443 cases, and they revealed that the successful utilization of the first generation this robotic systems, optimal ergonomics maintain the surgeon's endurance, and then you can actually work for a longer time. Sitting at a console with armrest is quite comfortable patient, and the free control of all the functions are there. So basically it's a very nice tool, but I don't know how much feasible in our context. So the first, this is the first robotic assisted flexible URS. The future of flexible URS, actually there are certain things to still to perform, like temperature control of the machines, wireless scope connections, artificial intelligence to be incorporated, and then multiple axis tip deflection. Now we just have up and down, so multiple axis deflection tip is required, and the sustainability of the flexible system is very, very important, especially for countries like ours. Otherwise the breakage of the system is causing a lot of financial issue for us. Thank you.
Thank you, Mahesh, for that very comprehensive lecture. Any questions? I think we can entertain a few questions from the floor.
Yes.
I'm Dr. Haris Qureshi. I have a question that in a few cases you placed the ureteral access sheet, I say 8 cases. So what were the indications that you decided to place and why not in the others? There must be something. And if you didn't place, so you only fragmented those stones and didn't extract them, or you extracted them?
No, initially we try to put an access sheet in all the cases, but nowadays because we do a URS before the procedure, and then we normally try to negotiate directly over the guide wire, and then no, we try to dust the stones. We never fragment the stones. We try to dust the stones and keep a DJ stand.
Any other questions?
Any other questions?
So I have one question. Yes. So you mentioned that you have seen least incidence of infections as you use disposable multiple times. So I would like to know that what techniques you have adapted to clean it up in the reusing or the
It's just
technique of sterilization.
just similar to reusable ones, except the heads are we just cleaned with the spirits and all. The head is quite sensible. If some irrigation fluid flows into the main head of the system, that will this electronic system will easily go off. So we just clean the head with the spirits, and rest we dip in the glutaraldehyde.
Thank you very much, Dr. Mahesh. I just want to add to one thing. It was a wonderful presentation giving us an overview of what is available in the market. You have mentioned Moses effect. I don't know what was the thought behind that, that you did mention that it was invented in Israel. I had a chance to meet the original manufacturer of this Moses laser, because it came into market in 2018 and 19 and almost vanished by 2020. So I asked him a specific question, that why did you keep the name Moses? So the answer was very simple. He's based in Israel, he's a Jew, and for them the prophet is Moses. But when I pointed out I referred him to the Quranic sayings that how the Moses was able to cross the river Nile. And now scientifically it is proven, if the winds are blown in particular direction, the splitting of the river can still take place unless you convince Allah Subhanahu that you are Moses. So because in the Moses laser, he said that actually we work in the water, and Moses was saved by passing through the river Nile, and Allah Subhanahu and split it. So I then named Moses. So now the Moses effect remains. The laser has been replaced by TFL now.
Yes.
Thank you. Thank you very much. Thank you, Dr. Mahesh. Wonderful presentation. We are grateful to you once again for traveling all the way from Kathmandu. It's lovely to have you here. Thank you very much.
Thank you, sir. I just like to mention that I'd like to thank the organizing committee for inviting us, and I've been invited in many in international meetings, and then I found that this is one of the best places I could have ever visited, and the people are so warm here. The hospitality is unmatched, unparalleled hospitality. So I would like to thank everyone, and I would like to welcome everyone to Nepal, during our conferences and maybe the personal visits if you want. We are ready to host you people, Thank you very much.
Thank you very much, Dr. Mahesh, for your big compliment. Thank you very much. Our next speaker is Professor Munawar Khalik. He will talk on troubleshoots in complex ureteroscopies.
I would like to discuss the troubleshoots in complex ureteroscopy. I'm Dr. Munawar Khalik. SIUT is comprised of different buildings, which is situated almost in Karachi, in Larkana and Sakhar. This is the center where the renal transplantation is also one of the well-known center in Pakistan. In the OPD, we have a lot of patients coming on daily basis, and where the renal stone, endourology, and these are all things takes place. The urolithiasis is the major clinical and economical burden in our health system. The ureteroscopy becoming the first line of treatment for the majority of stone disease. In past few decades, we have been many improvements regarding the endoscopic treatment of the urolithiasis. This reflects the current guidelines showing greater stone clearance in all the stones in the ureter. The guide wire is a standard tools in the field of endourology and interventional radiology, as well as in the interventional cardiology. I would like to have one study of a ureteric stone, which is 8,640, and conducted in SIUT in the June 2017 to June 2022. The age of the patient is between 15 years to 72 years, and the total number of patients, among the total number of patients, 5,760 were males and 2,877 were females. Male to female ratio is 1.49 to 1, and the ureteric stone size was 0.8 to 1.4 centimeter. All procedures were carried out in general anesthesia, in lithotomy position, and retrograde ureteroscopy was performed. A stone fragment with the help of pneumatic lithoclass or laser tripsy, and we have placed 34% cases, double J stent in 34 patients. We have about 47% females and 63% males. And these are the, among the stone, the age group is about 10% cases were between 15 to 20 years, and about 20% were 30 to 40 years, and about 5% were 60 to 72 years. The stone sizes we have about 67%, 0.8 to 1.2 centimeter. These are the results we have seen. The stone clearance was 97.3%, and post ESWL, post URS, if the stones is push into the kidney, they were dealt with the extracorporeal shock wave lithotripsy, and about 0.2% were failed to access through the URS, and about 16 patients were lost to follow. It is the basic principle of the ureteroscopy, the first performed urethrocystoscopy with the help of 0 lens and 30 degree lens, and appreciate the normal color of the mucosa, observe the normal landmarks of the urethra and bladder neck and ureteric orifice in 5 or 7 o'clock position. To pass the ureteroscope along the side of the guide wire, we first place the guide wire into the ureter and adjust water pressure in order to have distance, and you can pass easily the ureteroscope. Sometimes stones may not find along the ureter, and stone in the ureter, sometime in the ureter diverticulum, or it is in the bifid ureter. If you see the cystoscopic view of the bladder, there is a lot of trabeculations and diverticuli formation. So it is difficult to have to see the ureteric orifice in this way. We have to manipulate the distension bladder water, irrigation water, and also have a close look on the 5 o'clock and 7 o'clock position. This is again a trabeculated bladder. If the ureter is making fold or kink, then there is a difficulty in passing glide wire or guide wire through the ureter. So in this case, we have to place the patient in a Trendelenburg position so that that become easily glide wire easily pass into the ureter. In the same way, sometimes the lower ureter is become narrow, and it is difficult to have to pass glide wire. So we place at least for a couple of weeks DJ stenting so that the ureter become dilated enough to have next time ureteroscopy. In the same way, the proximal ureter also have kink and become elongated. And there is another case in which the guide wire could not be reached into the renal pelvis. So we make again with the Trendelenburg position so that the guide wire or glide wire can pass easily. The intraoperative complication, we have some major complication and minor complication. In major complication, usually have ureteric injury or mucosal erosion and ureteric intersuspension, and the worst complication is the ureter avulsion. uh, and the major bleeding can occur, and you can grade the ureteric injury in 0 to 5. In 0 grade, we have no lesion noted, and in the same way the complete transection in the grade 5. So simple ureteric erosion, mucosal erosion, you can pass DJ stent, and after some time it will heal. And if there is a avulsion of ureter, then you may have problem, and you can face either you open the case immediately, or you pass a PCN, and later on you make exploration again, and interposition of the ileal conduits also. In conclusion, ureteroscopy seems to be associated with more complication than currently reported, and the experienced surgeon should be able to recognize early and solve them to prevent the complication. Safety guide wire placed during the before every ureteroscopy. This enables the possibility of placing a ureteric stent at any moment. Thank you.
Thank you very much, Professor Munawar, for your nice talk. House is open for question or comment, maybe. If you look at the if you look at the real stories in ureteroscopies, so my question is how we prevent the retropulsion of stone when you are doing a ureteroscopy. Because if you are working in a high-tech institutes like SIUT, Kidney Center, Indus, etc., we are used to do practice, private practice. We do have very limited resources, very limited instruments from where we do the work. So how something which reduces the retropulsion of the ureteroscopy? Any comment from you or from the audience, maybe?
Before starting the ureteroscopy, we first pass a glide wire or sometime guide wire. It proximal to the stone, we make a coil of the guide wire so that the stone could not reach or could not go to the kidney. This is the way. Or sometimes we use baskets and different other instrument also.
But guide wire can itself push back stone into the system. Any comment, Dr. Javed, please?
I think how we can
Mike did.
while putting a guide wire.
Yes.
How we can make a coil after putting a guide wire?
Sometimes this guide wire become coiled proximal to the stone. If there is narrowing in the proximal ureter, then it becomes
Yes.
It would be distal to the stone or proximal to the stone?
proximal to stone.
There are specific catheters in the market, right? The catheters stone cone.
Yeah, I
Yes,
think
there is various instrument also available.
a question under discussion is how to prevent retropulsion. In fact, effectively nobody can prevent, but the balloons are available. Stone cone is available. Dr. Hamad sometime back presented that he can get past the gel, and the weight of the gel will probably
This is
retropulsion.
another way.
But seeing practically, if the stone is that obstructive, how you can pass the catheter beyond that to instill the xylocaine jelly? That was the question basically. I think I just wanted to complete my question. Would you please teach us that how the Trendelenburg position will overcome the proximal kink? Rather, I'm just wondering whether is it a Trendelenburg or a reverse Trendelenburg which will help? Otherwise, I mean, in my view, we are very lucky if any of these positions helps you to get over the proximal kink. But as you have mentioned, so we would like to learn that what is the anatomical reason behind that Trendelenburg will help you overcome the proximal kink.
Trendelenburg means the head down position. The diaphragm become push and it becomes because of the obstruction, the ureter become elongated and make a kink or folding in the ureter. So if you push, if you head down the position of the patient, then it is quite easy to pass glide wire first, and then it replaced with the guide wire later on.
And I would like to add a point that in non-high-tech centers, what can be done? We have to go back to the basics that we can give the patient, hydrate the patient well, that there is pressure from the kidney. You can give Lasix as well. And along with that, the main factor for retropulsion is that water flow, that how much that is going. And if you are using a pneumatic lithoclast, are you banging it like a Kalashnikov, or you are just focusing on it? What most of the people do, because we are at a teaching and training center, so our residents, and they put it on multiple shots and they start firing and the stone goes back. So you can put it on single shot that it fragments and doesn't retropulse. The water should be under control and you can hydrate the patient well. And as Dr. Munawar has said about the position, reverse Trendelenburg and Trendelenburg can be used simultaneously. So multiple maneuvers can be done, and last but not least, you can fragment those stones in pieces, and then you can find a place where the stone is directly adherent to the wall, and you can place it over there that it doesn't go up, it fragments there and then. So a lot of things can be done. These are the basics where no technology is needed.
Now, end of the day, then you say कि Allah कुछ तो है.
End में होना वही
Dr. Javed, can you add one of maneuver how to prevent the
yes, I just have a comment. Basically, what we are doing it, we have presented 2 patients yesterday. We are using stone cones frequently, so this is the best way to do that. But as far as concern the position, we are also using Trendelenburg position, 15-degree tilt down. This is actually
ureteric stone. See, everybody have a different sort of maneuvers which they do to overcome this retropulsion. What I personally do, majority of times I slow down or even stop irrigating fluid. So that would again will help you to, but in this you need a very much eagle's eye to not to damage the ureter. And another thing which you can do is, again, as Dr. Harris said, you have to keep your lithoclast on a single shot rather than on a multiple shots. And again, this head up would will help the avoidance of retropulsion.
anything from the junior colleagues can add something?
बोलिए आप रुकिए आप कुछ कहना चाहते थे?
Yes, actually,
like there was a study.
Just a minute. पहले उनको दे दीजिएगा.
Dr. GM को दे दें.
Actually, when proximal system is dilated, then retropulsion will be invited. So when we are frequently withdrawing URS out up to the bladder and keeping bladder empty, it will cause all the water or urine come down into the bladder and system will collapse, and stone will come distally with each withdrawal. So this is how we prevent more and more retropulsion stone. If we are seeing that the stone is going upward, we should withdraw so that system should decompress and simultaneously stone fragments will come down again, and you will have more time to break it.
I think we need to understand one thing, that a single shot lithoclast produces 1 mm of retropulsion, but if it on multiple settings, it can cause 3 to 4 mm retropulsion. That is much faster, especially in a kink ureter. Number three, anybody having an experience of using a Pathfinder? Pathfinder is a Indian device. Basically, it is a pipe connected with the balloon, just like a sphygmomanometer balloon. and actually when you compress it, it produces a water jet, especially in proximal ureter's kink. So it allows you, number one, to see that where are you actually approaching, and probably that water jet eddy currents may allow at times for your guide wire to pass on, especially the sensor one, because it has a longer flexible tip as compared to the glide wire. Yes, you are saying something.
Along with these various maneuver, I think the use of laser as compared with pneumatic lithoglass, there is a less chance of retropulsion with laser.
With regards to centers having difficulties socio-economically, we have experience of using the Wolf system of pneumatolithoglass, and beside all the factors that have been previously mentioned, I have personally, and I've seen my seniors using it as well, is actually trying to decrease the intensity, and that actually also helps prevent retropulsion. Beside switching from mono to multiple, if you decrease the intensity of the every single shot, it actually helps prevent the retropulsion.
Dr. Zakir, please, last comment.
So we have a desi jugaad for this. We attach a syringe from one side of the ureteroscope and put it on whether the surgeon is doing or an assistant is doing, they keep on giving a pressure shots to the path, so luckily might we pass through that kink.
Sir,
Thank you.
I have a question, but it is not related to retropulsion. It is related to, because this is a ureteral surgery session, so I think my question would help in thought-provoking regarding troubleshooting when the ureter, you cannot access the ureter through the ureteroscope when the stone is extremely stuck. So would the surgeons operating on ureter train for antegrade DJ stent placement? Because this is one of the domain of interventional radiology. But I think when the surgeon couldn't pass even the guide wire or the URS, then placement of antegrade DJ stent, if he is trained for it, then it would help instead of doing a PCN, just a PCN and then leaving the patient for the next few days.
If the guide wire is not going from retrograde, it is very difficult to pass guide wire from antegrade.
No, that's not true.
And for antegrade, you have to have.
You cannot pass a DJ. You cannot pass guide wire retrograde, but you can pass guide wire antegrade because
it would be same difficult as you are passing from the retrograde.
well, there is a chance. I am not saying that would be easy, but there is a chance that it might not pass into the bladder. But usually, it is not as difficult as antegrade that compared to retrograde.
I think as Dr. Zakir said, we have a local jugaad to push and dilate some lower part of the ureter and see some area, and then you can easily pass it.
मैं बोलूँगा और कोई नहीं बोलेगा. I think technically you are right that if retrograde में difficulty है तो antegrade में passage definitely easier hai. But you see, mind it, what is the cause of a proximal? Because I yesterday also mentioned, the pacemaker for the vermiculation of the ureter is in the pelvis basically, and that's why the proximal ureter get kinked. So once the upper kidney is drained by the PCN, next time once you go in, the kink will be over basically, by the way. So rather than being a very, although I have invented a technique to put in a DJ stent from antegrade especially, but that I use it in oncological cases. Thank you very much, Professor Khalik. It was wonderful, lovely talk. Ayaz साहब आ गए क्या?
Whenever you are intervening in antegrade patient, in terms of radiology, there are set standards or protocols. So if you are planning to do antegrade DJ stenting, first you have to place PCN. And it is not recommended radiologically that you intervene same time in ureter. So you have to have a phase in which you observe, you offer repeat cultures. Once they are negative, once the patient has no hematuria from the PCN side and it is the settled field, then you are able to intervene antegradely for DJ.
Otherwise, it is not a recommended policy or recommended thing to go directly from PCN to DJ placement in one setting. So this is a set rule.
Okay.
So you
Thank you, Dr. Kashif. Yes, thank you, Professor Munawar. Now, I would like to call Dr. Haris to give us a talk on his paper, Expression Therapy.
मैं 7:50 पे नाश्ते करते हैं। पापा आए तो नाश्ता आपके आगे पीछे भी है तो मैं तो टाइम का पापा मैं लोग साथ में मैं कहते सोए तो चल
So the mainstay of treatment for ureteric stones is surgery, and to make it dull, we'll be talking about medical expulsive therapy, and that is a non-surgical topic. And the slides are loading, so we have to wait for 2 minutes. Please start.
मैं एक वाक़या सुना दूं। हमारे जिस तरह से लेट सेशन चल रहे हैं तो कुरान मजीद में है कि जब हज़रत सुलेमान ने मोज़ेस को ये कहा कि कौन लाएगा बिल्कीस का तख्त, तो एक जिन है, उसका नाम है, कुरान मजीद में भी उसका नाम अफरियत है। वो उर्दू में हम इसको इस्तेमाल करते हैं, बड़े जिन को हम बोलते हैं और ख़बीस जिन को हम अफरियत बोलते हैं। तो उस जिन ने ये कहा कि मैं आपका दरबार उठने से पहले लाऊंगा। तो तफसीर इब्न कसीर में यह है कि उस ज़माने में वो 2 पहर दरबार कंडक्ट करते थे। तो हमारे यहाँ 24 घंटे को 8 पहर में तकसीम करते हैं, तो एक पहर 3 घंटे का हुआ। तो जिन ने ये कहा कि मैं आपके उठने से पहले तो विदिन 6 आवर्स वो लेके आएगा। तो आगे कुरान मजीद की आयत ये कहती है कि वहाँ पे एक साहब जो किताब का इल्म रखते थे, उसने कहा कि मैं आपकी पलक झपकने से पहले ले आऊँगा, और वो ले आए आप। तो एक तो ये अंदाज़ा लगाने की बात यह है कि जो किताब का इल्म रखता है और नबी का मानने वाला है, उसकी ताकत का यह हाल है, तो नबी की ताकत का क्या होगा। तो हमारे दोस्तों ने, पाकिस्तानियों ने टाइम को अफरियत की इंटरप्रिटेशन से देखा है कि जब भी वो 2 मिनट कहते हैं वो मुझे लगता है 5-6 घंटे हो जाएंगे। हारिस हो गया लोड क्या?
जी सर।
वेल डन यार।
आपकी हो गई सर कंप्लीट?
जी
हो गया। So let's dry up the session with a bit of medical topic of medical expulsive therapy. But while I was given this topic, I realized that a good surgeon is who knows when not to operate. So we will be talking about when not to operate. So I am Dr. Haris Hassan Qureshi. I am working as an associate professor at SIUT. You can see my social media handles, so you can follow me there and ask any queries or questions over there. So as we all know that medical expulsive therapy, the name indicates that how to get the stones out without operating, with medicines, with other therapies. There are a lot of things in the armamentarium. We'll be discussing it. What is the evidence? Because everyone says that we should give alpha blockers, we should give calcium channel blockers, a lot of things. So we'll be seeing what the literature says, and in the end, we'll be seeing what the guideline says. So a bit about anatomy of the ureter. It is divided into 3 parts. We know that proximal and distal. The iliac bone is the cutoff, and on which we can divide it into 2 parts, proximal and distal. There are a lot of drugs available pharmacologically, and they can contract and they can relax those ureteric muscle fibers, and there is selective alpha blockers, one of them. there are steroids, we can see calcium channel blockers, we can see potassium channel blockers, antimuscarinics. A lot of things are written in this armamentarium, but we'll be discussing only the relevant things regarding this. This is a very important slide, and we know that the ureter is divided into three parts: proximal, middle, and distal. But if you look at this distal part over here, we have got all the three receptors: alpha, A1, AR, AB, AR, and 1D, AR. So in the proximal and distal, they are not there, but in the proximal and mid, they are not there, but in distal part, they all three are available, which you can see on the extreme left side of this chart. So this is why there is a role of alpha blockers in relaxation of those smooth muscles in the distal part of the ureter. A bit about mechanism, as I've shown you, 1A, 1D alpha receptors are found in high concentrations in the distal part of the ureter smooth muscle, and that is why if we give these drugs, so they can relax the ureter and the stones can pass. We've got a lot of things in our armamentarium: alpha blockers, calcium channel blockers, and steroids have been tried, and now 5D, PDE5 excuse me, inhibitors can be used as well. So why we are using it? Because to relax and let the stones pass by, we need to know the size, site, and shape of those stones, and alpha blockers have been the mainstay of the treatment, and other things are now coming in, and we'll be discussing them. Is MET actually helpful or not? There are a lot of randomized, small randomized controlled trials, and they have shown its effectiveness. We'll be discussing it. There was a study conducted in 2006, published in Lancet. Hollingsworth et al. Concluded that patients given calcium channel blockers or alpha blockers had a 60% greater likelihood of stone passage than those who were not given. So this was a very treatment changing study in 2006. Then there were a lot of other studies. This paper was published in European Urological Journal in 2009, and Setz et al. Said in a meta-analysis of 47 randomized controlled trials that they compared the MET and concluded that MET with alpha blockers or calcium channel blockers improves stone expulsion rates, reduce the time of stone expulsion, and reduces the analgesic requirement, that the pain which was there because of the colic, that also reduced, and the size was 1 centimeter, 10 mm was taken as a cutoff. Then there was a study in 2007 by Glenn M. et al., and he said that when compared alpha blockers with nifedipine, there was not a significant difference between both of them. Is sildolicin better? Because a lot of people are using it now. In a recent systemic review of meta-analysis, Ozelsi et al. Compared two alpha blockers. They compared temsolucin with sildolicin as MET, and this was again meta-analysis and systemic review. 3 RCTs were compared, 2 of them were double-blind and showed significantly higher expulsion rates and faster expulsion times in favor of sildolicin and it with compared to temsolucin. So this was a study after which this drug also was used by urologists. Another thing was tried, corticosteroids. They said that there is inflammation and because of that there is edema, and let's solve it with steroids, and a lot of studies were done. This is a study from European Urological Journal in 2005 which showed that anti-inflammatory action can help facilitate those stones, because stone over there, it causes inflammation and then there is edema, and that stops the stone from passing by. But there was one randomized trial published as an abstract to support methylprednisolone on distal. Otherwise, we lack data. We don't have so much data over it. And there were a lot of complications of steroids as well, and that was causing problems. So there was no further evidence whether steroids were helpful in it or not. People compared excuse me, a lot of other drugs with alpha blockers as well, but because of the complications and they were causing, that was cumbersome. So phosphodiesterase 5 inhibitors were used in stone expulsion, and we know the mechanism that it acts by nitric oxide and cyclic GMP pathway, and it results in relaxation of the smooth muscle of the ureter, and stone passes by. A lot of studies being done. 2 references have been given over here. They were done, one in India as well. So when we discuss about MET versus placebo, so there was a very big revolutionary change in it when this paper was published in 2015, and that was called SUSPEND trial. There were 1136 patients taken, and they were decided to give in tamsulosin or nifedipine or placebo for 4 weeks, and they it was a blind study, and then they saw that there was no difference noted between active treatment and placebo between tamsulosin and nifedipine. So there was no difference in stone size, location or gender on it, and this study revolutionized that. For 20 years, 10 years, we have been giving alpha blockers for ureteric stones. They said that if it has to pass, it will pass, so there was no significant in it. Another study for MET versus placebo was done, and it is a double-blind study. Ferrick et al. Performed it, randomized double-blind study, and they also took the stone size of 1 centimeter in it, in distal ureteric stones, and they said that there was increased stone expulsion in the tamsulosin group, and if it is less than 5, it passed very well. So the dilemma continues. On one side we have got meta-analysis, on the other side we have got large high quality trials, and there is a lot of confusion that which is right and which treatment should be offered. Should we be offering MET or not is the biggest question. After that SUSPEND trial, after 2015, a lot of people changed their practice, because whenever they used to see a stone, proximal, mid or distal, they start giving alpha blockers. But after that SUSPEND trial, things change. So there was a very big confusion between a meta-analysis and multiple small low quality trials, so which one to follow. So now finally, in the last segment of my presentation, we will be discussing about the best clinical practice guidelines. We all follow guidelines because guidelines have got everything cooked up in it in one strong evidence or not. So EUA and AUA are the mainstay. AUA guidelines for stone endourological society guidelines were patients with uncomplicated ureteral stones less than 1 centimeter should be offered observation, and those with distal stones of similar size should be offered MET with alpha blockers. This is a strong evidence. The strength is grade B, and this study, this paper, this guideline is after that SUSPEND trial. SUSPEND trial was in 2015, and this is in 2016, and they keep on upgrading it. So they say that MET should be offered. Now about EUA guidelines, that they also say that consider alpha blockers as a medical expulsive therapy as one of the treatment options for stones greater than 5 mm. If the stone size is less than 5 mm, then let it pass on its own, it will pass. But if it is greater than 5 mm, they say that it will help in expulsion of that stone. So I guess a lot of things have been cleared, that what we have in our armamentarium, what we can offer the patients, all the guidelines and the evidence is in favor of alpha blockers, number one. And they say that if it is 5 to 1 centimeter or above, then you should be offering them medical expulsive therapy as alpha blockers, and other modalities don't have that much significance. And last but not least, there is a very big saying that it shall pass by like a stone. So if there is a ureteric stone, it comes from the kidney, it travels up to the distal ureter, eventually it will pass from the distal ureter as well. We have seen a lot of patients who are given alpha blockers for 4 weeks, 5 weeks, 6 weeks, and then we have to perform a URS on them. And a few patients we see, we ask them to come for the URS, they land up on the table and they say, in the morning I passed a stone. So there is no complete guideline for it, but the first thing was a good surgeon is who knows when not to operate. So a medical expulsive therapy trial should be given in that respected stone size. Thank you.
Thank you, Dr. Harris. Very good presentations. Here we will have only 1 to 2 questions. Yes, as we are running out of time here. If anyone have any question?
Yeah, I think, Harris, I will just ask one thing. Once you have done a URS and the stone has stuck, for example, in that scenario also, we give them alpha blockers and all that. Problem is, I think alpha blockers in that scenario we give it because we don't have anything. So just to cover up our being handicapped, we just give it. As you have very rightly mentioned, the stone passes possibly because the placebo compared trial confirms that this was an industrial gimmick going on. It was just like PSA, that we were doing PSA in 2008 for every patient and interpreting it, and now it has become controversial. So I think it is very good on your behalf to bring into the knowledge of our boys that this is not that effective and it carries as much value as of placebo. Thank you.
And I totally agree. And last comment, that a lot of people, they place a DJ stent and then also they give alpha blockers. In one study was done that DJ loop is causing lower urinary tract symptoms, so it will prevent that as well. So somehow the pharmaceutical thing comes in between. But I guess we have clear with the guidelines. Thank you.
ये जो एक टिकट में 2 मजे हैं, ये इसमें आपकी drug of choice Silas है?
Sorry?
जो आप
alpha blockers.
Alpha नहीं.
जी, Temsul.
दवा कौन सी देते हैं? किस नाम से?
नहीं 5PD.
Alpha blocker देते हैं.
नहीं 5PD में तो आप Silas देते हैं या Viagra?
उसमें तो वो एक जोक है, वो मैं आपको अकेले में बताऊँ.
Thank you very much. We have next speaker. It was Professor Ahmed Fawad, but somehow he was not been able to make it. And Dr. Atif Javed will be actually presenting his presentation, and that is obstruction plus sepsis, antibiotic stewardship versus empirical approach. Dr. Atif Javed from Ziauddin University, Karachi.
So, Assalamu alaikum. Before I start my presentation, I want to thank the organizers for giving me a chance, and also pray for speedy recovery of Dr. Ahmed Fawad. So since I've made it on a very short notice, so probably if there is some shortcoming, I apologize for it. So let's start with the topic. It's obstruction plus stasis, obstruction plus sepsis, antimicrobial stewardship versus empirical approach. So since this is kind of a clinical scenario, so I will also like to start my talk with a case. So it's a 56-year-old male, known case of diabetes, which comes with a complaint of right-sided flank pain along with nausea and vomiting and fever with rigors and chills. Recurrent stone former. He's on glucophage. On examination, he is febrile with tachycardia and right renal angle tenderness is positive. So the labs show leukocytosis with TLC count of 28,000, and electrolytes are that sodium is 129 milliequivalent per liter. Pus cells and bacteria are numerous, and urine CS has been sent and results are awaited. Ultrasound shows right-sided hydronephrosis and hydroureter with right renal internal echoes suggestive of infection.
And again, CT confirms this diagnosis with an obstructing calculus in proximal ureter at the level of L4. So we manage this according to our standard guidelines. We give IV fluids, correct electrolyte imbalance, give analgesics, and then renal decompression is done. So this is followed by empirical antibiotics, and this is what backed up by guidelines. But the million-dollar question comes here, that which antibiotic is to be selected here. We are selecting it empirically, but how we can know that what is the best antibiotic to which the patient will respond. So basically there are these 4 ways to select the antibiotic. Empirically, it's either personal choice, they are either textbook recommendations, guideline recommendations, or we can choose it through antimicrobial stewardship program or ASP. So we'll discuss all of them one by one, and also I would like to discuss that why this proper selection is so important. So first, the personal experience. People usually give it under their personal experience or with observation. There's no scientific basis. They are not backed up by any evidence, and there are high chances of failure. So surely this is not a proper way to recommend and choose and select antibiotics here. Then come the textbook recommendations, which are based on regimes published in textbooks, and different regimes are there in the different books, so the thing becomes confusing. They are evidence-based, but that evidence usually gets outdated after 1 or 2 years of the publishing of that textbook, so and it cannot be applied universally. So there are again high chances of failure. So just an example, this is the empirical antibiotic chart given in the Smith urology, where for complicated UTI, they say that first choice are fluoroquinolones. But when we come to the Campbell-Walsh urology, there's long list of the antibiotics, and when they specify, they narrow it down, they say that trimethoprim is the first drug of choice. So again, we can't rely on them. Then come the guidelines, which is very important for all of us. We all follow guidelines in our day-to-day practice. Since they are updated regularly, they are based on evidence. They are different, but part is that different guidelines are used in different parts of the world, and every guideline has its different recommendations, which are based on the research articles coming on from their respective regions. So although there are less chance of treatment failures, but still failure rates are significant, especially for our part of the world, because there are no such studies coming from our part, and especially in the case of infections, they are not applicable in our region. So just to emphasize my point, these are the guidelines of European Association guidelines, where amoxil plus aminoglycosides, and when we come to the AUA guidelines, there are no specific drugs mentioned. So all of this has come to inadequate empirical antibiotics, which leads to the consequences of antibiotic resistance, so that they cannot be used empirically. The worst outcome from the infection, this resistance results in treatment failure, prophylaxis failure, and then obviously there are cost effects as well. So as a result, what is happening? These bugs are winning. Initially, we used to see the most of the drugs which were working on these bacteria. Then comes the era of MDR, that most of the antibiotics were not acting on these bugs, and now we are seeing XDR, extensively drug-resisting organisms, where most, only 1 or 2 we usually see that medicines do work on these microorganisms. So it is a growing problem, with more than 2.8 million antibiotic resisting infections occur in US only each year, and more than 35,000 die as a result, according to CDC's 2019 antibiotic resistance threat reports. And obviously it has got financial effect, and estimated national cost in USA to treat these infections is substantial and exceeds more than $4.6 billion annually, the reserves which State Bank has right now. So, and this situation continues. It is estimated that by 2050 it will become the biggest killer for humans, with the numbers approaching 10 million per year in the 2050. So we have got these studies. This was the study published in the very initial time when antibiotic resistance started, and it concluded that adequacy of empirical antibiotic treatment is an independent risk factor for mortality in patients with E. coli bacteremia. MDR E. coli bacteremia had a worse prognosis due at least in part to a lower frequency of correct empirical treatment. Again, in this study, it is concluded that antibiotic resistance significantly impacts on the patient's illness burden. In the community, patients are more likely to experience delays in clinical recovery. And then this comes a very important study from Pakistan, which says the scenario of antibiotic resistance in Pakistan. It was a systemic review of many studies, and it showed that there are many multiple organisms which are becoming MDR or XDR, and in the study of Elizabeth et al., all the 33 isolates of Salmonella were XDR. So they concluded that antimicrobial resistance pattern of common pathogen was high against commonly prescribed antibiotics, regularization of monitoring practice, regular local and national monitoring, molecular investigations, and particular efforts to address the risk associated with rise in antibiotic resistance are required. And this was an eye-opener. It was a threat alert by CDC that alerted the travelers to the Pakistan about XDR typhoid fever, and they suggested to avoid non-essential travel to Pakistan. So the condition is really getting worse now. So how to control this antibiotic resistance? There are many ways. Either we can develop new drugs and vaccines, improve diagnostics, infection prevention, education, research, and obviously research, and reduce resistance reservoirs, and central to all is the Antimicrobial Stewardship Program, or ASP. So what is it actually? It is basically a coordinated program for the appropriate use of antimicrobials in order to improve patient outcome and reduce microbial resistance. And it decreases the spread of infections caused by MDR organism. It promotes appropriate selection of antibiotics, appropriate dosing, and route and duration of antibiotics. So the main goal is to have the right drug for the right person over the right time frame. The primary goal of it is to optimize clinical outcomes, minimizing unintended consequences, that is toxicity, MDR selection, and this selection of pathogenic organisms, and secondary goal is to reduce the cost effects related to resistance. So basically, this is the antibiotic stewardship program structure, where multiple departments of a hospital or community work in collaboration to control the chances of antibiotic resistance, including microbiology, primary physicians, IT, pharmacists, epidemiologists, and nursing staff. So all they work in collaboration to choose the right antibiotics so that this antibiotic resistance problem is not emerged. It can be implemented on different levels, like hospital, and then GP level and individual levels. So these are the studies which reported on the results after implementation of ASPs, and this first study, which was actually a Cochrane review, concluded that these interventions are effective in increasing compliance with antibiotic policy and reducing duration of antibiotic treatment, does not increase the mortality and reduce length of stay. In this another study, stewardship programs are useful tools for optimizing antimicrobial therapy. They may contribute to preventing increased bacterial resistance and to reducing the long-term financial cost of antibiotic treatment. In another study, it was concluded that judicious use of antimicrobials and resources can improve a patient's safety metric and decrease cost effects dramatically. So, but how to implement it?
Dr. Atif, time please.
Okay, sir. It's just an example that if we see as a primary physician, if we refer back to our case, if we see this primary infection, and as a primary physician, I will call ID consultant. He'll prescribe this antibiotic empirically by taking the records of antibiogram from microbiologists, who will have all the data of likely work from this complicated UTI and its effective treatment against it. So he will tell me the appropriate dose and according to the disease behavior and severity, and meanwhile, as primary physician, I'll send urine cultures before and after decompression and blood cultures, obviously after primary management of the disease. So the ID consult recommendations go to the pharmacist, who recommend about appropriate dose and route of administration, and then comes the role of support staff for the proper drug delivery and handling. Like if the drug is photosensitive or temperature sensitive, it should be dealt accordingly. So then comes the nursing staff, who is responsible for proper drug administration and observe any adverse reactions. And then comes the epidemiologist, who will record all the data regarding cultures and sensitivities. He will record any untoward effect, any incident, and drug toxicity and efficacy, and this will be helpful in future audits and maintaining the antibiograms. And meanwhile, the microbiologist will get the result of urine cultures and suggest upon the proper antibiotics to be given to the patient. So this is how, this is a very simple, it's just takes some time to implement the program, and then it is very easy to conduct. But if we see the condition after this ASP introduction in Pakistan, that snapshot, which it was a snapshot article, and it concluded that there are inadequate ASPs among the hospitals of Pakistan. A multidisciplinary approach, clinical leadership, and availability of enthusiastic and motivated individuals are essential elements. Similarly, in this another article, it was concluded that doctors working in the public sector had inadequate knowledge about ASP. There was no proper system in place. The local antibiograms and antibiotic prescription guidelines were not available, and there is dire need to implement strategic objectives of National Action Plan of Pakistan on AMR in order to mitigate the adverse outcomes of AR in future. So although this is a emergency call for us, since it is a very growing and very alarming situation in Pakistan, but still we are at very initial levels. So from this forum, I request to implement this ASPs. We have implemented it in Ziauddin Hospital, and we have found it very easy to work out. So just finishing my presentation with this quote from Winston Churchill: "A pessimist sees the difficulty in every opportunity, and an optimist sees the opportunity in every difficulty." Thank you so much.
Thank you very much, Dr. Atif, for a very comprehensive presentation. Because there is a time constraints, I take this opportunity to say thank you very much to the organizers once again, and it is a really honor for me that I am co-chaired by my two very wonderful students who have a great sense of humor And thank you very much, Dr. Waqar, and thank you very much, Dr. Said Qadri. Thank you very much. Thank you.
Thank you.
बहुत हो गया बहुत हो गया
The last session of today's eve is free paper session. I would like to request Dr. Hafiz Qureshi to please come on stage as a chair. Dr. Raja Razwan, please come stage. Dr. Taimur Jatoi and Dr. Shaukat Mughal. Ansar, please come here.
Should we start, Imran? Assalamu alaikum and good morning again. So we have a free paper session today, and the first paper is Holmium laser lithotripsy versus pneumatic lithotripsy for the lower ureteric stones, and that will be presented by the Dr. Bilal Akhtar, DHQH Gujranwala. No, okay. Acha, okay. So I think the presenter is not available. So we have a second paper by Dr. Anam Ansari from JPMC. Is she there? Okay. So we have a third paper by Dr. Fahad Abdul Malik. Okay. So this is the paper from SIUT, the ureteral wall thickness in a patients undergoing ESWL treatment in a proximal ureteric stones. You have a 5 minutes for the presentation. Okay. So be on time.
Assalamu alaikum. My name is Dr. Fahad and I am from SIUT, and today my presentation is proximal study of prospective study of ureteral wall thickness in patient undergo ESWL treatment for the proximal ureter stone. We use CT KUB axial section for this study and the ureter wall thickness is measured. The objective was to determine association between ureter wall thickness and stone clearance among patients with proximal ureter stones undergoing ESWL treatment at tertiary care hospital. Methodology: all patients who fulfill the inclusion criteria and visited to our center SIUT were included in this study. Informed consent was taken after explaining the procedure, risks and benefits. In our study, we divide the patients into two groups. Patient who has ureter wall thickness more than 5.2 mm will consider as an exposed group, while who have a ureter wall thickness less than 5.2 mm was considered as an unexposed group, and stone clearance was assessed after 6 weeks. And the results are: the mean age in the exposed group was 38 and unexposed group also 38. In the group-wise distribution, the gender was 66% males and 33% females in the exposed group, while 73% in males and 26% females were included in the unexposed group. The stone clearance was observed less likely in the exposed group as compared to unexposed, with a relative risk of 0.5, and the p-value was found to be highly significant. This is the pictorial presentation of my data. Stone clearance among the unexposed people was very high, 83.3%, while non-stone clearance only 16%. But in patients who have more than 5.2 mm ureter wall thickness, the results were only 56% of stone-free clearance, while 43 has a failure. So we concluded that highly significant relative risk of incomplete stone clearance was noted among exposed group as compared to the unexposed group. So a cutoff is ureter wall thickness of more than or equals to 5.2 mm is associated with increased risk of incomplete stone clearance. So the take-home message from this is ureter wall thickness is an independent parameter along with stone size, stone density and BMI that also affect the stone-free rate in Pakistan after ESWL for proximal ureteric stone. Thank you.
Well, just a suggestion from my side. Your study title doesn't show that what you are looking for. It should be clear that you are looking for stone clearance or what outcome you want from your study.
Sir, basically in my study, I see the stone clearance rate among the patient who have a obstructed stone in the proximal ureter, and we give more patients a ESWL session. So my study concludes that if there is obstructed stone in the proximal ureter, we should do the CT scan. In CT scan axial section, we measure the ureter wall thickness If there is obstruction, edema, and there is more ureter wall thickness, don't give ESWL.
Nice presentation. As you said, you were looking for the wall thickness. Any comment on the stone sizes? Because you said it was independent factor.
Yes,
Weren't
sir.
you considering stone size for your study?
Yes, I have considered a stone size of 10 mm cutoff.
Both groups?
Yes, sir.
Okay, any other question from the audience? No. Okay, thank you, Dr. Fahad.
Thank you.
So we have a next paper that is will be presented by Dr. Sana Tariq from the Kidney Institute, Karachi. Is she there? Okay. So we have another paper by Dr. Muhammad Zafar Ahmad from SIUT. Is he here? Okay. So this paper is impact of skin to stone distance and the stone volume on the stone clearance and operative time in a patients undergoing PCNL, a tertiary care center experience. Dr. Muhammad Zafar.
Assalamu alaikum and good morning to the panelists and my colleagues here. The topic of discussion for me today would be impact of skin to stone distance and stone volume on the operative time and stone clearance in patients undergoing PCNL, a tertiary care center experience. So before I proceed, I would like to highlight the inclusion criteria for the study. All the patients who were included had given informed consent prior to participating in the study. The ages of around 18 to 60 were included, either gender, and obviously as the guideline says, stone size of more than 20 millimeters, but no past surgical history of being operated for stone disease on the affected site. Non-contrast CT KUBs were performed at our institute prior to undergoing surgery. So this is the graphical representation thanks to the Department of Radiology from SIUT and how we went on and calculated the skin to stone distance. 3 distances were taken in 3 different axes and a mean of the total distance was taken as a reference. A total of 151 patients were taken, with the males comprising 72% while females 27.8%. Dividing it into positional approaches, the patients who underwent supine PCNL amounted to 61 while prone to 38.4% respectively. So this is the descriptive analysis. I'll try to shorten down the discussion and talk about the 2 main variables that were part of the discussion, that is the operative time, the minimal skin to stone distance in millimeter, and stone volume. The mean operative time for our study amounted to almost 160 minutes. Minimal skin to stone distance was found out to be 8.14 millimeters and a stone volume of 7,407 in millimeter cube, that is. So just for references, a retrospective study done by Masood Y and his colleagues compared the skin to stone distance in patients going through PCNL without flexible nephroscopy, that is exactly the system that we used, and the skin to stone distance was found to be at 8.89 centimeters. So coming to stone clearance, in the number of patients that were declared as stone-free with no residual fragment post-PCNL, the amount was at 83.4% stone clearance, with 16.6% patients not having some residual calculi post-procedure. So now this is again comparable to stone clearance size by numerous studies performed prior. One such study performed in Nepal was by Dangal and his colleagues, which showed clearance of around 90%, and there was another study that was conducted by Reddy SV and his colleagues, which showed the stone clearance undergoing PCNL at around 94%. So, the hallmark, operative time versus stone volume. So we found out a significant positive Spearman correlation between stone volume and operative time. That is, if the stone volume goes up, the operative time goes up as well, with a significant p-value of 0.043. Now, the operative time versus skin to stone distance. There was no significant relationship seen between the operative time and the skin to stone distance, with the constant of Spearman being at minus 0.179 and the p-value at 0.028. Now coming to stone clearance versus median stone volume in millimeter cube. So the patients who had their stones cleared, the median stone volume stood at around 7,710.9 millimeter cube, and the ones who had residual fragments post-procedure had their stone volume prior to procedure standing at 15,458 respectively. Now, another indicator is stone clearance versus stone volume. Now, this graph beautifully explains the patients who had their stones cleared. Their median stone volume, as prior mentioned, stood at 7,710. But the ones, now the thing that stands out from the study is the ones who could not clear their stones. The modal value stands at around 10,025 millimeter cube of stone volume. So this is the volume. This is the volume at which patients started experiencing, or the ones which had residual calculi post procedure. Now, stone clearance versus skin to stone distance. There was an insignificant correlation determined between skin to stone distance and stone clearance. Hence, no relationship was found. Now, I would like to lay emphasis on the BMI relationship and along with the stone clearance. Now, it can be easily said, and it obviously understandable as well, that as the BMI goes up, the stone clearance falls down. So, conclusion. Well, feasibility of PCNL as an evolving modality for optimal stone clearance in the developing world. Low complication rates and internationally accepted procedural outcomes in the study. Legitimizing concerns for tubeless approach, the new way forward. Rigorous enforcement of awareness amongst urologists for making patient-centric decisions with imaging in mind. And the preponderance of stone volume as the new predictor for stone clearance. Skin to stone distance has no impact, as contrary to the beliefs earlier, on outcomes of PCNL in terms of stone clearance and operative time. And a need of a further pilot study in future comparing approaches, including the emerging energy platforms in the future. Thank you.
Thank you, Dr. Zafar. Any question from the audience? No question. Okay. Thank you, Dr. Zafar.
Thank you.
We have another free paper by Dr. Mushtaq Hussain. Is he there? Okay. So this paper is on exceeding the effectiveness of ESWL to post PCNL residual stones, a comparative study with the primary stones of the same size. Dr. Ghulam Mustafa will present.
Assalamu alaikum. So, you all have heard the objective. The hypothesis is stone-free rate of ESWL on post-PCNL residual stone is higher as compared to stone-free rate in ESWL on primary renal stones of the same size. This is related with density or Hounsfield unit measurement of these stones. So in methodology, prospective cohort study done at SIUT, sampling technique is non-probability consecutive sampling. 108 patients were enrolled and two groups were made. One was the patient with residual stones after PCNL 5 to 15 millimeter, and other was the primary renal stones without any previous history of intervention. Inclusion criteria was all patients with renal stones of 5 to 15 millimeter, either primary or post PCNL, were included with the age limit of 20 to 60 and both genders. Pregnancy, patient with pyonephrosis and sepsis and solitary kidney and renal anomalies were excluded from this system. Lithotripsy was done by a single surgeon in both groups, and patients were followed by ultrasound and X-ray KUB, and a stone-free rate, yes or no, was noted after 8 weeks of the procedure. Stone size and density was compared. Stone size in group A, that is post PCNL residual stones, was 1.1 plus minus 0.25, and in primary group it was almost same. And stone density was slightly lower in primary stone groups, that is 1028 Hounsfield units, and in post PCNL even harder stones were found. And total number of lithotripsy sessions were almost equal, 1.28 in post PCNL group and 1.5 in primary stone groups. So results were compared and found that post PCNL there was very much good clearance result after lithotripsy. That is almost 90%, and only 10% patients were resistant to lithotripsy post PCNL. And in primary renal stones, only 55% of the stone clearance was found, with similar findings on the CT scan. Stone density was compared in both groups. There was average or mean 1048 in primary group, and stone clearance was found to be better in less than 1000 or 869 Hounsfield unit stone cases. So in conclusion, this effect of Hounsfield unit was more prominent in patients receiving lithotripsy for their primary stones, but ESWL was evenly effective on post PCNL residual stones, even in harder stones. Thank you. Any questions?
What do you think? What is the reason that same Hounsfield unit and the post PCNL clearance is better?
It is as per hypothesis that when a stone is coming across to some energy previously, as in PCNL, these stones after fragmentation and fragmented stones do better with lithotripsy compared with primary renal stones, which are never dealt with any energy before.
Any question from the audience? From Dr. Mustafa? No question? Okay, so we have another paper by Dr. Elahi Baksh. He is here. The outcome of mini PCNL in a pediatric population and experience from a resource-strained tertiary care center. He is working at the Gumbat, and so this is one of the government setup which have started and doing a lot of work at the Gumbat, providing the free healthcare facility. Dr. Elahi Baksh.
Thank you very much, Mr. Hafiz Qureshi, for good remarks. So, my paper is on the outcome of mini PCNL in a pediatric population experience from a resource-strained tertiary care center. The prevalence rate is much higher in the low-income countries. That is the Asian belt, which includes Pakistan, India, Bangladesh, and Nepal. So, the map shows the incidence is more, prevalence is more in Pakistan, in Sindh and Balochistan ports. That is 16 to 19 patients per 100,000 populations. The purpose of showing this mini PCNL picture, that the morbidity and the risk of severe complications of PCNL associated with the diameter of the instrument. So miniaturization of PCNL can minimize the complication rates with minimal incision, reduced hospital stay and post-operative pain. So objective to assess the efficacy of mini PCNL in a pediatric population and evaluate the outcome of mini PCNL in a pediatric population in terms of post-operative complications and hospital stay. The estimate the efficacy of mini PCNL for stone clearance in pediatric population. This is a prospective interventional cross-sectional study. This is designed in the Pir Abdul Qadir Shah General Institute of Medical Sciences, Gambat, Khairpur, Sindh. Study duration was conducted between 1st June 2021 up to 31st August 2022. The inclusion criteria 2 to 17 years of the age old patients, single renal stone. This is the initial part of my study. I used to take single renal stone in the pelvis with no associated anomaly, stone size more than 1 centimeter up to 3 centimeters. The exclusion criteria: anatomical abnormalities, multiple renal stones, renal plus ureteric stones, and recurrent stones. Data was entered, analyzed using SPSS version 20. Mean standard deviation will be calculated for independent variables like age, weight, stone details, and operative time. Normality of data was checked with the help of the Shapiro-Wilk test, and the frequency and percentage will be calculated by quantitative variables. Effect modifiers like complications, operative time, hospital stay, control through stratification, post-stratification, and chi-square test was applied, keeping p value 0.05 as significance. So mean age of the study participant was 7.5 years with a deviation of 8.89 years. Gender distribution was male dominant with 75%. Laterality of the stone identified 12% left side, 77% the right side, while 11% had bilateral renal stones. No residual stone indicated in the follow-up radiological investigations identified 100% clearance of the stone rate with 90.9% complete clearance was achieved. Residual stones were identified in 9.1% of the post-operative radiological investigations. 5.7% patients underwent ESWL, while 3.4% needed redo PCNL with 100% stone clearance. So total number of the patients were 87. 8 patients had residual stones. 5 out of them underwent ESWL with 100% stone clearance, and 3 went redo PCNL with 100% stone clearance. The initial initial is learning curve. 2 patients of PCNL done that developed sepsis. I performed in 1 patient the double prick with once the tract was lost, made second time tract. The patient had a post-operative hematuria and residual stones that developed sepsis, the longer hospital stay. And as further I continued. Up to now, I have done more than 200 PCNs. That 87 out of them, 87 is taken for this study. So stent size can alter the hospital stay in the pediatric population. As in our study, patients with the larger stones were reportedly stayed longer in the hospital as compared to the patients with the smaller stones. With the 2 patients had developed post-operative sepsis that were hospitalized up to 14 days. So operative time was measured and documented in minutes. The results indicated comparatively longer operative time in the stone size more than 2 centimeters, as the variables are showing in this diagram. This is the picture of one of my smallest patients we operated for PCNL. Conclusion and recommendations: the reducing blood loss, hospital stay with maximum achievable stone-free rate are primary endpoints for a pediatric urologist. The aim to use mini PCNL less than 16 FR implant sheet is to achieve these endpoints. Outcome of mini PCNL was exceptional in pediatric population of a study with 90.91% of the stone-free rates. It had recommendations of tiny skin incision and restricted tissue handling leading to the early recovery. Mini PCNL signify important mean of managing simple and complex renal stones in children with an operative time with stone-free rate. Minimal mini PCNL results in a shorter hospitalization and less hemoglobin drop. Thank you. Any questions?
Very well done, as you are doing these cases in a very small, in a remote area of Sindh. So very well done. But do you have a facility of angioembolization over there?
Yes, he started there. Angioembolization.
Oh.
Yes.
Yes, Dr. Hina.
Yes.
So, who did you subject to lithotripsy? Who did you subject to PCNL for dealing recurrence of the stones?
These were the residual stones in which I performed. In those patients having stone size less than 1 centimeter residual, I performed ESWL. The burden was more than 1 centimeter, 1.5 centimeter, I performed PCNL.
Another question from the audience. Thank you, Dr. Eli Baksh. Very well presented, and I have a very good clearance, 90% and more than 90%.
Thank you.
And very well done, because you are doing a very marvelous job at the Gambit Institute. And I think the SIUT is also doing a pediatric PCNLs at the Sakhar or not? I am not sure about it. RS. Okay, so very good. Okay, thank you so much. So we have another paper by Dr. Ghulam Mustafa, prone versus supine PCNL care center, a tertiary care center experience.
So objective is to compare outcomes of PCNL in supine versus prone position. Experts and my teachers are here, so no introduction. PCNL in both supine and prone position was performed by experienced urologist. Position was selected on the basis of stone location and pelvic LSL anatomy after retrograde study. And around 200 patients were equally divided into two groups. Groups were compared in terms of mean operative time, complication, stone clearance rate, and hospital stay. Results were analyzed using t-test and chi-square test, and p-value of less than 0.5 was considered as significant. 70 patients were female and 130 were male. 52 patients had multiple stones, while 148 patients had single stone in the pelvis. Average BMI was found to be 24.8. Average stone size was 2 centimeter, ranging from 1.2 to 6 centimeter. Mean age was 35 years, 11 to 70 years of the patients. 158, 79 had complete stone clearance, while 21% had partial clearance, and only 24 out 26 and 28 aplasies. Standard PCNL sheath was used. 138 patients had lower KLSL approach. Procedure time in supine, average procedure time was 65 minutes, and in prone it was 80, longer duration in prone. And it was stone clearance was complete in 77% in supine PCNL and 81% in prone PCNL, and partial clearance was 23 in supine and 19% in prone PCNL. Number of stones in supine, single stones patients were 78, and in prone 70, and multiple stones were found in 22%, and in prone it was 30%. Calyx punctured in supine PCNL, it was less likely to puncture lower calyx, only 3, upper calyx only 3 upper calyx puncture was there, and middle and lower calyx punctures were more. And in prone 39 upper calyx punctures and 51 lower calyx punctures, and middle calyx was punctured in 10%. Hospital stay was less than 2 days in most of the patients, 91% in supine PCNL and 88% in prone PCNL, and only 9% in supine stayed more than 2 days, and 12% in prone PCNL. Amount of fluid used was almost same in both groups, and less patient has used more than 10 liters of the fluid. And complications were found. Post-op bleeding was more in prone PCNL, that is 4%, and post-op collection was even more in prone PCNL. Hydrothorax was more common in prone PCNL and chest tube placement. And there was a single gut injury in supine PCNL, and otherwise sepsis and post-op ileus transfusion and drain placement were similar in both groups of PCNL approach. And this is the representation of complications in both supine and prone. So it was found pelvic LSL system can easily be assessed in both groups. Mean operative time in supine group was significantly less than prone in this study. And the stone clearance rate was 81% in prone and 77, that was almost similar. Hospital stay was found similar in both groups, and complication rate was slightly higher in prone group. So conclusion, supine PCNL is safe and effective in selected patients, and as it gives more room for the procedure. Procedure is surgeon and anesthesia friendly. It has potential advantage of less patient handling, single drape procedure, and enables to perform simultaneous ureteroscopic procedures, thus reducing overall operative time and the similar stone clearance rate as compared to prone position. Thank you.
Well, Dr. Majid Rana is here. He is expert in supine PCNL, but you said that complications are more in prone position. But you mentioned one gut injury in the supine PCNL. I think gut injury is a big complication. So if you compare the complication burden, I think if you injure the gut, that's a big issue for the patient. What do you think?
Definitely, gut injury is big issue in cases of PCNL, and patient will have more scar than otherwise when we are doing PCNL. But it happens.
And any question from the audience? Dr. Majid Rana says it's TK. Okay. So we have the next presenter by Dr. Muzammil from Indus Hospital, Karachi. And the topic is, can CT parameters predict the spontaneous passage of the ureteric stone, single center study?
आगे आगे
बिस्मिल्लाहिर्रहमानिर्रहीम Bismillahirrahmanirrahim. Good morning and assalamu alaikum to everyone. I am Dr. Muzammil Hassan, resident urology at the Indus Hospital and Health Network, Karachi. Today I am here to present my paper entitled, Can CT scan parameters predict the spontaneous passage of ureteric stones, a single center study? Okay. I'll start off with the objective of my study. It was to determine the CT parameters, that is the values and measurements stone and ureter related among the patients having successful spontaneous passage of ureteric stones, and also to determine the frequency of spontaneous passage of ureteric stones in patients diagnosed with ureteric calculus. The rationale to conduct this study was that there are a number of potential CT-based predictors, stone and ureter related, that are available to facilitate the management of ureteric stones. There is a need to test whether and which of these factors can also augment the successful, predict the successful spontaneous passage of those stones. And according to the results, we categorize the patient in the favorable CT, patients having favorable CT markers and patients having unfavorable CT markers. Patients having favorable CT factors do not go a surgical procedure which could easily have been avoided, and on contrary, patients who are having unfavorable parameters for the spontaneous passage should undergo early intervention rather than lingering on the medical expulsive therapy. Okay, the methodology. The study period was between February 2022 to August 2022. And it was conducted at the Indus Hospital. A total of 136 patients were included in the study who met the inclusion criteria. Non-contrast CT scan done initially for the confirmation of diagnosis, and CT parameters were recorded. The CT parameters were assessed to predict the spontaneous passage of ureteric stones. METS therapy was given to all patients, and all patients were reassessed again after 4 weeks. Okay, the inclusion criteria, patients giving informed consent, both genders, ages between 18 to 75 years, and patients diagnosed with symptomatic ureteric stones confirmed on non-enhanced CT scan. An exclusion criteria was any patient requiring emergent intervention, multiple ureteric stones on one side, and the pregnant females. CT parameters which we recorded were divided into two main factors, stone factors and ureteric factors. Stone factors included the size, location, and Hounsfield unit density. And ureteric factors were ureteral wall thickness, ureteral diameter above the stone, and the ureteral diameter below the stone. And the results, I'll go quickly. As you can see, the p-value is significant for all. Stone size 6 or less than 6 was a favorable factor for the spontaneous passage. Moving on to the stone density, a stone density of 700 or less was also a favorable factor in the spontaneous passage of ureteric stone. Ureteral wall thickness 3 or less than 3 was a favorable factor for the spontaneous expulsion of the stone. And the diameter greater than 8 above the impacted stone of the ureter was an unfavorable factor in the passage of spontaneous stone. And the diameter below greater than 5 mm of the diameter of the ureter below the impacted stone was a favorable factor for the spontaneous expulsion of the ureteric stone. And the location, which we all know, the distal and the mid ureters had higher rate of spontaneous expulsion rather than as compared to the proximal ureteric stones. The frequency total in around 136 patients, 59 patients were those who did not pass the stone spontaneously and they ultimately required an intervention, and 77 patients were those who passed the stone spontaneously, and all these patients who passed stone spontaneously at least have had 4 or more favorable factors on the CT scan which predicted the spontaneous passage of the ureteric stones. So, conclusion and take-home message: the spontaneous passage of a ureteral stone can be predicted with high accuracy with the information available on non-enhanced CT scan. By precisely studying the CT scan parameters, we can easily avoid the unnecessary surgical and anesthesia stress. It will also be helpful in reserving the resources and saving the cost. Further prospective studies are needed to accurately predict the spontaneous passage. Thank you.
Thank you, Muzammil. There's one question from Dr. Tembur.
Thank you, Muzammil. Nice presentation. Your study was very closer to the SIUT1 who presented, but you had more parameters. Most of the parameters I can agree with you, but what about the relation of Hounsfield unit with the passage of stone? Can you comment on that? as your supervisor is sitting very next to me.
So Hounsfield unit basically tells how hard the stone is. A harder stone has more propensity to density.
Passage from the ureter.
Yes, it has more difficulty in passing and it can cause trauma and edema. However, the soft stones are less likely to cause edema and trauma to the ureter, so they are less likely to stuck up.
Thank you. Any other question from Dr. Atif? He's smiling. So, Dr. Ghazanfar have a question.
Well, I have not studied about this exactly, but yes, there was. I did not study about the gravity effect of gravity exactly, but the heavy stones which I studied was, which I told to this to sir as well, that it causes more trauma to the ureteral wall, and it is more prone to cause edema to the walls. That's why it gets stuck up easily, and spontaneous passage is difficult in those stones. For gravity, I'm not very sure, because peristalsis is the main thing which is propulsing the stone in the ureter. So role of gravity I have not studied.
Okay. Thank you. Very well presented, Muzammil. Okay. So we have another paper from SIUT, Muhammad Naseem. Is he here? So the topic of that paper is recovery of the renal function after the relief of obstruction in a unilateral obstructed kidney due to impacted ureteric calculi. Muhammad Naseem.
Thank you, Quraishi.
Bismillahirrahmanirrahim. My name is Dr. Muhammad Naseem, resident urology, SIUT Karachi, and my paper is on the recovery of renal function after relief of obstruction in unilateral obstructed kidney due to impacted ureteric calculi with contralateral normal kidney. The objective of my study is to determine the recovery of renal function after relief of obstruction in unilateral obstructed kidney due to impacted ureteric calculi. Methodology: this study was conducted on 182 patients presenting with obstruction in unilateral obstructed kidney due to impacted ureteric stone, both gender included, with age range of 18 to 70 years. Patient with diabetes mellitus, hypertension, pregnancy, bilateral ureteric stone, salivary kidney, and pre-op renographic split renal function less than 10% were excluded from the study. Recovery of renal function was assessed in all patients with MAC3 scan. Pre-op renographic split renal function of the ipsilateral kidney was obtained, and then the renographic arenoscopic split renal function of the ipsilateral kidney was obtained at 6-week post-op. Result: this study was conducted on 182 patients, and the mean age of the patient was 45 plus minus 15 years. According to the gender distribution, there were 64, means 35% males, and 118, 64% females in our study. The frequency of recovery of renal function is that out of 182, there was a recovery of renal function in 113, and there were no recovery or stable renal function in 169 out of 182, 37%. Take home message: kidney with renographic split renal function of less than 10% are irreversibly damaged, while there is an improvement or stabilization of renal function can be expected after relief of obstruction of kidney with a renographic split renal function of 10% or greater.
So, thank you, Mohammad Naseem. Any question from the audience? So, Mohammad Naseem, I have a comment about do you expose every patient of who have the unilateral obstructed kidney and you remove the stone and you go for the MAC3 scan in every patient?
Yes.
So how do you
okay. Only the one with impacted ureteric stone.
Okay. How do you get the ethical approval from these patients? Because you are unnecessarily exposing every patient who have the URS, removing the stones, and exposing the MAC3 scan, because it's, I think, no, every patient. He said obstructed kidneys. In 182 patients, obviously impacted stone, you go for the removal of the stone. So do you get easy ethical approval for this MAC3 scan, because exposure of these radionuclide scans have the adverse effects?
Yes, but that much of the student was with impacted ureteric stone, means there was URS was less, can be less helpful.
Impacted stones with a longer duration or any duration you like?
URS can be less helpful in that impacted ureteric stone with.
Dr. Harris can.
Actually, when we perform MAC scan, we don't only see that the patient has got a ureteric stone only. There are multiple things which has to be seen. So the duration, as Dr. Harris said, that what is the duration, what is the cortex size, what is the calyceal anatomy of that patient, and then it is not that the patient comes to your clinic and you plan it and the next day you get a MAC scan done. So there is no unnecessary radiation given or any unnecessary test done, but where needed, because most of the times what happens is you remove that stone and then the patient's obstruction is relieved and the patient gets the MAC scan or something after 1 year, 2 years, 3 years later, and the kidney is 15% or 20% functioning, and he says that because of that URS my kidney became 20%.
So not in every patient, I think. Okay.
Satisfying the patient, because you have to justify the treatment as well.
Yeah, but if not satisfying the patient, it is ethically wrong that I perform that URS in that patient who needs a nephrectomy. Then I perform 2 surgeries on that patient. How can you justify in court or anywhere in medical related thing that a patient has got 10% functioning kidney and I am fragmenting that?
Right.
So there are multiple aspects you have to see for the betterment of the patient, and we have got a very strong ethical system at SIUT.
That's why I was asking about. Okay, thank you. Okay, then they do it. Okay. So we have only the last 2 papers from the Tabba Kidney Institute. By one is the Subhan Ahmad Sajjad. Is he here? Okay. So this study is the comparison. No, sorry. This is the comparison of outcome of a pneumatic lithotripsy, Holmem laser lithotripsy, and combined electromagnetic with ultrasonic lithotripsy during PCNL. Subhan Ahmad Sajjad, Tabba Kidney. I would suggest Dr. Yasra Fahim that she should give the presentation to upload it, because it takes time to upload the presentation, to save the time.
Bismillahirrahmanirrahim. I am Dr. Subhan Ahmed Sajjad from Tabba Kidney Institute, Karachi, and the topic of my article is the comparison of outcomes of pneumatic ballistic lithotripsy, holmium laser lithotripsy, and combined electromagnetic with ultrasonic lithotripsy, which is also known as trilogy, during mini percutaneous nephrolithotomy. The objective of my study is to compare the outcomes between combined electromagnetic with ultrasonic lithotripter, pneumatic ballistic lithotripter, and the holmium laser lithotripter among the patient presenting at a tertiary care hospitals in terms of stone-free rate, operative time with lithotripsy activation duration, and the post-operative complications. The stone-free rate is defined as no calculus on the ultrasound during the follow-up, and the lithotripsy activation duration is the time after started after the lithotripter introduced in the nephroscope till the clearance of the stone, and post-operative complications were observed till the discharge of the patient. This is the picture I have put in my presentation. It is trilogy, combined electromagnetic and ultrasonic lithotripter. Just a single institute prospective study with simple randomized technique. A total number of patients were 60, which were divided into 3 groups, each with 20 patients. The group A get pneumatic lithotripsy, group B get laser lithotripsy, and the patients of group C get trilogy lithotripsy. Patients of age greater than 18 years with renal stones of 1 to 2.5 cm with variable Hounsfield units were included in my study. Also, the pregnant females and patients having severe cardiopulmonary intolerance to surgery, urinary tract abnormalities, and coagulopathies were excluded from this study. In my study, 18 French implant sheet was inserted with a 15 French nephroscope. So my results shows, as you can see, the mean stone size and stone density were comparable. As you can see, the statistically insignificant p-values. P-values for mean lithotripsy activation duration was significant and was less for the group A among the 3 groups, followed by group B and then the group C for both hard stones and the softer stones. I would like to point out that lithotripsy activation duration decreased for the softer stones in group C as compared to the harder stones, but still not in the comparison with the other groups. In group C, 5 lithotrites modalities were converted. In 2 cases, probe was broken down as it is a very delicate probe and difficult to handle. And in the 3 cases, we were facing difficulty in fragmenting harder stones, so modality was converted. Maximum grade of complication in my study was grade 2, which was seen in group A and group C. That is post-operatively blood loss, which we monitored by hemoglobin drop, for which PCV transfusion was required. There were a total of 3 patients in group C with a grade 2 Clavin-Dando classification, according to Clavin-Dando classification. And in the last, as you can see, the stone-free rate was statistically insignificant between the 3 groups. As per our study, the conclusion with the stone-free rates being comparable in all groups, pneumatic and laser observed to be better in terms of lesser operative time and better clearance of better stone-free rate of harder stones than trilogy in mini PCNL. So my take-home message, as per our study, trilogy was observed to be a weak modality for mini PCNL as we used 18 French implant sheet, and also due to cost-effectiveness. But as per other literature, is a good modality of stone fragmentation in standard PCNL in terms of operative time and stone clearance for both hard and softer stones. Thank you.
Thank you very much. So we have a next presenter, Dr. Yasra Fahim, and she will present the mini PCNL versus RIRS for renal stones less than 2 cm single-centered prospective study.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Yasra Fahim, resident of urology practicing at Taba Kidney Institute. On behalf of my institute, I am going to present today a topic relating minimally invasive percutaneous nephrotomy outcome versus RIRS outcome for when we are considering management of renal calculi up to or less than 20 mm. Purpose of this study was to see which of the two procedures have a better safety and efficacy profile. It was a single institute based prospective study which was conducted over a span of 1 year. We took a total 60 patients and all patients were more than 15 years having renal calculi up to or less than 20 mm, and these 60 patients were equally divided into two groups. Group A underwent mini PCNL which had 30 patients, and group B also had 30 patients who underwent RIRS. We consider different variables which include stone-free rate, post-op HP drop, or total operative time, post-op complications, and in total in-patient hospital stay. Stone-free rate was defined as no calculus on subsequent follow-up ultrasound KUB, and first post-procedural follow-up ultrasound KUB was scheduled after 4 weeks of procedure to see any residual calculi. For evaluation and comparison of complication, we use the Clavien-Dindo classification. Starting from methodology, in group A patients underwent mini PCNL in which we use 18 FR implant sheet and with the 12 FR nephroscope, stone fragmented via pneumatic lithoclast. Group B patients underwent RIRS in which we use 9/11 FR axis sheet with 7.4 FR by 9.5 FR flexible uterorinoscope. Stones were fragmented via holmium laser with a fiber size of 200 micrometer. 7 of the group B patients required pre-procedural stenting because of the tight ureter. So coming on the result, we consider both the preoperative and postoperative variables. In the preoperative variables, the demographic characteristics of patient including age, BMI and gender had no statistical difference. Also stone characteristic like number, location and density were also statistically insignificant, but most of these stones were located in lower calyx. This is the chart that is basically showing post-operative characteristic in which we can see that two of the variables, total hospital stay and operative time, had significant p-value. So hospital stay was shorter for group B patient, that is who underwent RIRS, with a mean duration of 1 day. Whereas patient who underwent PCNL, they had mean 2 days duration for hospital stay. P-value was significant less than 0.001. Total operative time though was shorter for patient who underwent mini PCNL with a mean duration of 52 minutes for mini PCNL, whereas for patient who underwent RIRS they had 74 minutes. P-value was also significant, that is 0.002. Regarding post-operative transfusion, only 2 of the patients who underwent mini PCNL, they received post-operative transfusion. One of the patient had gross hematuria and required angioembolization on day 10 or 12 post-operation, whereas one patient required blood transfusion only in group A, that is who underwent mini PCNL, but p-value again was non-significant, 0.229. Stone clearance rate when we compared in between the two procedure was non-significant, that is both of the patient has had comparable stone-free rate. Coming on conclusions, so when we are considering management of renal calculi, both mini PCNL and RIRS have a comparable stone-free rate, but mini PCNL patients had longer hospital stay and greater risk of post-op complication. So RIRS being a less invasive procedure makes it a safer procedure as compared to mini PCNL, as the patient will have less chances of post-op complication and shorter hospital stay, early return to their physical activities. Thank you.
Thank you, Dr. Isra. Any question from the audience? No. Okay. So,
operative cost in total?
Yes.
That is not so different. I mean, the mini PCNM patient has around 1.5 lakh, and RIRS patient have 1 lakh around.
Dr. Saeed Qadri will.
Okay, thank you very much. So now I conclude the session. This free paper. Thank you, Dr. Taimur. Thank you, Dr. Rizwan, and thank you, Dr. Shokat. So I conclude this session. Thank you.
So with this, we conclude our this Hyderabad Urology conference, and I must be very thankful to our senior, our teacher, Professor Majid Rana, who stayed with us from the first day of the conference, from hands-on till the last day. And I am also thankful to our senior colleague and President PAUS Pakistan, Professor Ayaz Khan, staying till the last moment, Professor Ejaz Ahmed, and faculty from Indus, SIUT, staying with us. Thank you. Lastly, I will ask Professor Ayaz Khan to conclude the session, conclude the conference, sorry.
Assalamu alaikum. I'm thankful to all of you that you've been staying with us, till the end. The people who are here, and especially our senior most, fellow Dr. Majid Rana is with us, and it's a great honor for us that he is here, especially in the session of urolithiasis, since he's a very well-known figure in the stone disease throughout the world, I would say. I would congratulate the Hyderabad chapter that they really managed the event very well, and it's a great start, and hopefully under the auspices of PAUS, Pakistan Association of Urological Surgeons, we would be continuing this kind of seminars, workshops, inshallah, in future. And the most important thing regarding these events is basically the learning of urology. Especially it's for the residents and for all of us. We are sharing our experiences, our knowledge. Regarding the residents, I would say that they should try their best to present the best papers. They should try to work on the research, and this is the time actually, and in the whole world, I mean, the credit goes to the research work now. The people who are expert in coming here, standing on the dais, having a good presentation, I think that's the best thing that you would have, and that would count to your credibility. So the resident must put their efforts in starting their research works in their respective programs. They should write papers, and they should present in the national, and they should go to the international conferences as well. From the PAUS standing, I would say that inshallah, if our residents tries, we would also support them to join into, to support them to go to the international conferences as well, and present over there as well. I'm thankful to all of you. You participated very actively, and especially the Hyderabad chapter, Dr. Zakir, Kashif, Dr. Javed, Altaf, everybody here. I mean, they really, Dr. Imran, they did very well, and I congratulate all of you. Thank you so much. Thank you.
बहुत सारे लोग यहाँ पे नाम नहीं दिए गए